If you work in the NICU, you know there's really nothing that gets your heart racing quite like a ventilator alarm going off, especially on your smallest, most fragile patient.
It's a sound that just cuts through everything.
It really does. I mean, we're operating right at the very edge of viability. And this machine, the ventilator, we often treat it with this mix of awe and honestly a lot of intimidation.
That's the core challenge, isn't it? We see trainees approach it like a magic box of knobs.
A recipe, just set the pressure to this.
Right. And our whole mission really is to get everyone to move beyond that, to move from, simple knobology to a real mastery of the physiology.
Because the ventilator is just a tool.
It's just a tool. The real magic is understanding the patient's lungs, the compliance, the resistance, how all of that changes, second by second. Once you get that, the settings become intuitive, they become tactical, and most importantly, they become a whole lot safer.
Okay, so let's unpack that right now and build that foundation. If you take away only one thing today, it has to be this one golden rule of respiratory support.
I know what you're going to say.
It's that ventilation success is governed by two completely separate, totally distinct physiological goals. You can think of them like two bank accounts that you absolutely cannot mix up.
That's it. You have your oxygenation account and you have your co-euro removal account or your ventilation account. And they are independent. They need completely different interventions.
So oxygenation is all about what?
It's about volume and stability. It's about getting the lung open and keeping it open so gas exchange can happen across that membrane.
And then the co-euro removal of the ventilation part, that's all about flow and movement. You're physically washing gas out of the system, in and out.
And this is so critical because we see it all the time in a crisis.
The baby is desaturating, their oxygen is low, and someone cranks up the respiratory rate.
And you've done absolutely nothing to solve their volume problem. You've only addressed the flow.
Conversely, if the co-ears is climbing, cranking up the FIDO, the oxygen isn't the answer either.
No, you need more flow, more movement. You need to increase the minute ventilation. Getting that distinction right from the start is the bedrock of everything we're going to talk about.
So let's clearly define those two goals and the specific controls we use to manage them. Let's start with the absolute core fundamentals of the lung.
Okay, so goal number 1, oxygenation, OROs. As we said, it's a volume problem. We need to optimize gas exchange. And to do that, we really only have 2 main controls.
The first one's easy. FIRO, the fraction of inspired oxygen. It's just the concentration of oxygen we're allowing. But the second one, that's where the real art comes in.
I mean, airway pressure, MAP.
This is the ultimate recruitment pressure.
It is. MAP is the average pressure in the airways over the entire breath cycle inspiration and expiration. It's the single most important number that determines how much of that lung is actually held open and participating in gas exchange.
And the physiological goal of manipulating MAP is all about optimizing the functional residual capacity, the FRC.
Right. For anyone needing a quick refresher, FRC is the amount of air left in the lungs after a normal passive exhale. You need an optimal FRC to get the best VQ matching possible.
The ventilation perfusion ratio.
Yeah.
Where the air you deliver actually meets the blood flowing past the alveoli.
Exactly. If your FRC is too low, your alveoli are collapsed, your VQ mismatch is high, and the baby desaturates. Simple as that.
But this is where it gets tricky, right? Because increasing MAP isn't free. There's a trade-off.
A huge trade-off. To increase MAP, you can either increase your PEEP, the positive end expiratory pressure, or you can increase your inspiratory time, your time. Both hold pressure in the lung for longer.
But high MAP means high pressure inside the chest.
And high intrathoracic pressure is the enemy of cardiac output, especially in a sick neonate. That pressure squeezes the great veins, it impedes venous return to the heart, and your preload can drop.
So you can get hypotension. You can compromise the whole system.
So every single time you reach to turn up the PEEP or the T to fix oxygenation, your very next thought has to be, how is this baby's perfusion? You're always trading lung recruitment for hemodynamic stability.
Okay, so that's the oxygenation account. Now let's flip to the other one. Goal 2, ventilation, getting rid of co-euro.
This is pure flow, pure movement. We need to move gas in and out efficiently.
And the control here is minute ventilation. The math is simple. And it's your absolute guide. Minute ventilation equals respiratory rate times tidal volume, or VT.
That's a non-negotiable physiological law. If the QO is too high, you have to increase the rate, or you have to increase the volume of each breath, or both.
So let's just summarize the action plan then. Low euro, You need more MAP or more fine arrows. You're focused on volume.
And high CRO. You need more rate or more tidal volume. You're focused on movement. Stick to that, and you will avoid, 90% of common vent management errors.
Okay, so we have the goals. Now let's talk about the physical properties of the lung itself. The engine room mechanics, if you will. We always use this balloon analogy to talk about the two big concepts, compliance and resistance.
Right. Compliance tells you how stretchy or how stiff the lung is, how willing it is to accept a certain volume of air.
The formal definition is the change in volume per unit, change in pressure. C equals delta V over delta P.
So a low compliance lung is a stiff lung. Think of a brand new bicycle tire. Or clinically, think of a preemie with severe RDS who doesn't have surfactant. You have to push really, really hard to use high pressure to get even a tiny bit of volume into it.
And that automatically puts you in a high-risk zone for injury because you're using those higher pressures.
Exactly. Conversely, a high compliance lung is like an old flimsy plastic bag. It's super easy to inflate with almost no pressure, but that's not always a good thing.
Right. In a chronic BPD lung, for instance, that high compliance can mean the lung has lost its elastic recoil. It's easy to get air in, but it's hard for the baby to get it back out.
And that leads us straight into the second property, resistance. Our resistance is just the opposition to airflow, and it is almost entirely determined by the diameter of the airway.
The ETT, the breathing tube, is a huge part of this. And this is where the physics, the Poiseuille's law becomes, it becomes a daily clinical weapon for a neonatologist.
This is so high yield. Everyone listening needs to burn this into their brain. Poiseuille's law says that resistance is inversely proportional to the radius of the airway raised to the fourth power.
To the power of 4. That exponent is everything. It means tiny, tiny changes in the airway's radius lead to absolutely colossal, dangerous changes in resistance.
Let's put some numbers on it. If you have the radius of a tube, you increase the resistance 16-fold. 16, it is not linear, it is exponential.
So think about your patient. A tiny 2.5 millimeter endotracheal tube has roughly 10 times the resistance of a 4.0 millimeter pediatric tube.
10 times, and that's just the clean tube itself. Now add the clinical reality. What makes that radius smaller? Mucus, edema from suctioning, thick meconium in a MAS baby.
If that 2.5 millimeter ETT gets even a little bit clogged with secretions, say 25% occluded, the resistance just skyrockets to a level that can make it impossible for the baby to breathe through. It drives up their work of breathing and causes dangerous air trapping.
So the clinical imperative is twofold. First, always use the biggest ETT you safely can for that baby's size. And second, you have to be obsessive about keeping that tube clear. Absolutely clear.
So if your patient suddenly crashes, high pressures, looks like they have high resistance, your first thought before you even think about an X-ray has to be obstruction.
Always. Is the tube blocked?
Okay, so if compliance and resistance are the building blocks, then the time constant is the master blueprint. This is the concept that tells you how to set your timing on the ventilator, your inspiratory time, and your rate. This is everything for safety.
It's a beautifully elegant concept. The time constant, which we call tau, is simply compliance multiplied by resistance. Tau equals C times R. And that number tells you the time in seconds it takes for the lung to fill or empty by about 63%.
But 63% isn't good enough, right? For real gas exchange, we need the lung to be almost completely full or empty.
Exactly. The clinical rule of thumb is that you need 3 to 5 time constants to get to 95 or even 99% completion. So before you touch the rate or the inspiratory time, you have to mentally estimate the baby's time constant based on their disease.
Let's walk through the two big clinical extremes. First, a short time constant.
This is your classic early RDS lung. It's very stiff, so compliance is low, but the airways are usually clear, so resistance is normal. Low C times normal R gives you a very short time constant.
So the lung fills fast, and maybe more importantly, it empties very, very fast.
Right. And because it empties so quickly, we can use faster rates, 40, 50, even 60 breaths per minute. And we can use shorter inspiratory times, or TIEs, maybe 0.30 to 0.35 seconds.
The risk here isn't air trapping, it's the opposite. It's collapse, atelectasis. That stiff lung just wants to snap shut the second the breath ends if your PEEP isn't high enough.
Now for the other extreme, the long time constant. This is your classic BPD patient, or a baby with severe meconium aspiration. Here, the resistance is very high, and the compliance is often variable, or floppy.
High R is the dominant factor, so the time constant, tau, is long. The lung fills slowly. but it empties even more slowly.
And that is the whole ballgame. If the lung empties slowly, you absolutely must give it a long enough expiratory time, or TE, to let all that air get out before the next breath comes in.
If you don't, you get breath stacking. You trap air, you develop what's called auto PEEP or intrinsic PEEP, and you put that baby at a massive risk for a pneumothorax.
Let's use a quick example. Say you estimate the time constant for your BPD baby is 0.5 seconds. You need at least 3 of those to empty the lungs, so you need an expiratory time of at least 1.5 seconds.
If you set a rate of 60, your total cycle time is only 1 second. Your TE is going to be way too short, and you are guaranteed to cause air trapping. You have to do that math at the bedside.
Every single time.
Okay, final foundational concept. The pressure volume curve. The PV curve. This S-shaped graph is basically our roadmap for lung protective ventilation. It shows us exactly where we risk causing injury.
It has 2 landmarks that you absolutely have to know. The first is at the bottom of the curve. It's called the lower inflection point, or LIP.
And if you're operating with pressures below that point, what's happening?
You're wasting your time and hurting the lung. Below the LIP, the alveoli are collapsed. You're pushing in pressure, but getting almost no volume in return. You're just repetitively opening and closing those fragile lung units.
It's the shearing injury we call atelectatic trauma.
Precisely. So the rule is you have to set your PEEP, your positive end expiratory pressure, above that lower inflection point. That PEEP is your anti-atelectatic trauma force. It's what keeps the lung stable.
Okay, so once we're above the LIP, we get into this nice, steep, linear part of the curve.
That's the sweet spot, the linear compliance zone. This is where small changes in pressure give you beautiful, proportional, efficient changes in volume. This is where gas exchanges best and injury is minimized. This is our therapeutic window.
But if we keep pushing the pressure up, we hit the second landmark at the top, the upper inflection point, or UIP.
And above the UIP, the lung is overdistended. The curve flattens out again. Now you're adding tons of pressure, but the lung is already full. You're getting no more volume. You're just stretching the tissue beyond its limit.
And that excessive stretch is the mechanism of volutrauma.
The single biggest driver of chronic lung disease. So to prevent volutrauma, our peak pressures, or our target tidal volumes, have to stay strictly below that upper inflection point.
So there's the whole blueprint. Keep above the LAP to stop atelectatic trauma, and peak pressures below the UIP to stop volutrauma. Just stay in that linear zone. That's how you become a master clinician.
That's the essence of lung protective ventilation.
All right, we have the physics, we have the physiology. Now let's get into the toolbox. The actual modes of ventilation we use, and how the whole paradigm in the NICU has shifted towards smarter, safer strategies.
Well, the history of this really started with some pretty rigid and now, frankly, outdated modes. The first was intermittent mandatory ventilation, or IMV. We call it the dumb mode.
Why dumb?
Because it just delivered breaths at a set rate, completely ignoring what the baby was trying to do. It was totally unsynchronized.
And that fighting between the baby and the machine, I mean, the consequences were devastating.
Absolutely. You'd get these massive swings in pressure inside the chest and abdomen. It dramatically increases the risk of pneumothorax, air leaks, and this is critical for preemies intraventricular hemorrhage, IVH.
Because those sudden changes in blood flow to the brain.
Exactly. So IMV is, for all intents and purposes, obsolete now. The next step up was all about synchronization.
Which brings us to SIMV, Synchronized Intermittent Mandatory Ventilation. This is the polite mode.
Much better. Here, the machine waits. It waits for the baby to make a small effort, and then it delivers the mandatory breath in sync with that effort.
And SIMV is really popular for weaning, right? You can just slowly turn down the number of mandatory breaths and let the baby do more of the work.
You can, but there's a huge clinical detail that people often forget. Between those mandatory breaths, the baby is still breathing on their own.
Right, spontaneously.
And if you don't give them some help, they're breathing against all the resistance of that tiny ETT and the circuit. You have to add pressure support or PS.
Usually what, about 6 to 10 centimeters of water?
Something like that. Just enough to overcome that resistance and dead space. It makes a massive difference in their work of breathing and prevents them from getting tired.
Okay, and then the final conventional mode is assist control, or AC, sometimes called SIPPV. This is the full support mode.
Right. With AC, every single time the baby makes an effort to breathe, they trigger a full, completely supported mechanical breath.
This sounds great for a really sick infant who you don't want wasting any energy. It maximizes comfort and synchrony.
It does, but it has one massive glaring risk, and that is, what if the baby is breathing fast for a reason that's not respiratory?
Like pain. or a fever.
Yeah.
Or a bad metabolic acidosis.
Exactly. In AC, they're going to get a full mechanical breath for every single one of those rapid efforts, and you will rapidly hyperventilate them.
Driving the Paccawatos way down, causing a severe respiratory alkalosis.
And that hypocapnia causes the blood vessels in the brain to constrict, which we know increases the risk of white matter injury, PVL, in preemies. So if your patient is breathing fast on AC, you have to ask why before you walk away.
All right, so those are the conventional modes. But really, the field has moved on to something much smarter. Let's talk about volume guarantee, VG.
This is the game changer. All those other modes are pressure targeted. You set a pressure and you get whatever volume that pressure generates. Volume guarantee flips that script entirely. The target is the volume.
So how does it work?
It's a beautiful feedback loop. As the clinician, you set the desired tidal volume, the VT, in milliliters per kilogram. The vent delivers a breath, measures the volume that came out, and then automatically adjusts the pressure for the very next breath to hit that target volume.
Breath by breath.
Breath by breath, all while staying under a safety pressure limit that you also set. And this automatic adjustment is why VG is just so superior, especially for neonates whose lungs can change on a dime.
Let's go through the reasons why. The 3 Ps of why VG is so good. The first P is it prevents volutrauma.
Right. Since your target is a safe, limited volume, like 5 milliliter, the machine simply cannot overstretch the lung. It can't go past that upper inflection point, no matter how much the compliance improves. It's built-in lung protection.
Second P, it prevents atelect trauma.
Yep. If the baby's lung suddenly gets stiffer, maybe they get a mucus plug, a pressure-controlled mode would now deliver a tiny, inadequate volume. But VG automatically increases the pressure to make sure that target volume is always delivered, which keeps those lung units from collapsing.
And the third P, and this is just transformative in the NICU, is auto-weaning. This is where it gets really interesting.
Okay, picture this. You've just given surfactant to a baby with severe RDS. Their lungs are incredibly stiff. Within minutes, their compliance can improve by 50% or more.
If you're on a standard pressure-controlled mode, that fixed pressure you set is now going into a much stretchier lung.
Yeah.
You're going to deliver a massive, dangerous, volutraumatic tidal volume.
You're going to blow a hole in that lung. But VG removes that risk completely. It instantly senses that the lung is stretchier, and it automatically turns down the pressure needed to achieve your safe, set volume. It weans the pressure for you in real time.
And makes that post-surfactant periods so much safer.
Dramatically safer.
And the volume targets themselves matter, don't they? It's not one size fits all.
Not at all. For that acute, stiff RDS lung, we aim low. Maybe 4 to 5 mil-NQS. We prioritize protection. But for a chronic BPD lung, we often have to target higher volumes, sometimes 6 to 8 milliQS.
And why is that?
Because those scarred, damaged lungs have a lot of increased physiological dead space. Wasted ventilation. You need to deliver a larger total volume just to get enough of it to the parts of the lung that are actually working.
Okay, so what happens when even our best conventional modes, even VG, aren't enough? Or when the pressures we need are just too dangerous?
That's when we have to escalate to high-frequency ventilation, or HFV. This is a totally different way of thinking. We're using tiny, tiny tidal volumes, often less than the dead space, at super fast rates.
Let's start with HFOV, high-frequency oscillatory ventilation, the vibrating lung.
This mode is unique because it has both active inhalation and critically active exhalation. A piston or a diaphragm literally vibrates the entire column of air at anywhere from 8 to 15 hertz. That's 480 to 900 breaths a minute.
And the strategy here is called the open lung concept.
It is. The main goal is recruitment. You set the mean airway pressure, the MAP, deliberately high, often higher than you would on a conventional vent. The goal is to pop open every single collapsed alveolus and hold them all stable. Then you use these tiny rapid pressure wiggles, the amplitude, to move gas in and out.
And this is where the settings get really counterintuitive for new trainees. On HFOV, if your baby's oxygen saturation is low, what do?
You increase the MAP, you want to recruit more lung, you're solving the volume problem.
Okay, but if the pseudo is high and you need to ventilate better,
you need bigger wiggles, so you increase the amplitude, or the delta P. But here's the confusing part. You can also decrease the frequency. Lowering the hertz gives each wiggle a tiny bit more time, which allows for a slightly larger tidal volume with each oscillation. So lower frequency equals better CO removal.
Lower hertz equals better ventilation. You have to remember that.
You do.
Okay, then there's the other type, HFJV, high-frequency jet ventilation, the pulsing stream.
This one's different. It uses these short, high-velocity pulses of gas for inspiration, but exhalation is completely passive. The lung just recoils on its own.
And you always use this with a conventional ventilator running in the background, right?
Always. The conventional vent is there to provide the PP and the baseline size. The jet's clinical niche is very specific. It's for air leak syndromes, things like pulmonary interstitial emphysema, PIE, or a really persistent pneumothorax.
And why is it better for air leaks?
It's that passive exhalation. It gives trapped gas that's in the wrong place in the interstitium a chance to escape more easily. The active push-pull of HFOV can sometimes trap that air even further. HFJV just lets it bleed out.
So for adjustments on the jet, ORO is controlled by the PEEP from the conventional vent.
And Kyoka is controlled by the jet's peak inspiratory pressure or its rate. The choice between HFOV and HFJV really comes down to the underlying problem. Do you need aggressive, constant recruitment for a uniform disease like RDS, that's HFOV, or do you need to gently manage severe air trapping and leaks, that's HFJV?
So we have the tools. Now we get tactical, because you can't just apply one strategy to every baby. The stiff lung of RDS needs a completely opposite approach from the floppy, obstructed lung of BPD.
Exactly. Let's start with RDS. The defining features are atelectasis from surfactant deficiency. So you have a very stiff, low-compliance lung, but it's usually a homogeneous disease. The whole lung is affected similarly, and critically, it has short time constants.
So the battle plan is simple. Recruit and stabilize.
Right. And we always want to start non-invasively if we can. Early CPAP or NIPPV at 5 to 8 centimeters of water to establish that FRC before things get too bad.
But if you have to intubate, the strategy is VG-centric. A low tidal volume, maybe 4 to 5 millivolt. You need adequate PEEP, 5 to 8, to keep those alveoli open once you've recruited them.
And because those time constants are short, you can use fast, efficient cycles. Short inspiratory times, 0.3 to 0.35 seconds, and higher rates, 40 to 60 a minute. The lung can handle that speed because it empties so quickly.
The big turning point is always surfactant. You give it early if the FIO is creeping up past 30 or 40%, but this is a moment of very high risk.
Extremely high risk. If you are not on volume guarantee, you need to have your hand physically on the PIP knob ready to drop it the moment that compliance improves, or you will cause massive volley trauma.
But VG does that for you. It auto-weans the pressure, which is a huge layer of safety.
A vital layer of safety.
Okay, now let's flip to the complete opposite. Bronchopulmonary dysplasia, BPD.
The BPD lung is a totally different beast. This lung is scarred from previous injury. You have fibrosis, lots of heterogeneity, high airway resistance, and floppy airways from tracheobronchomalacia. They have long time constants, and air trapping is your number one enemy.
So if RDS is stiff and fast, BPD is floppy and slow.
You've got it. The strategy here has to be one of patience and gentle stenting. Because the time constant is long, you need a longer inspiratory time, maybe 0.40 to 0.50 seconds, just to get the air in.
And most importantly, you need a very long expiratory time to let that air back out against all that resistance.
Which means you have to use much slower rates, sometimes as low as 20 to 40 a minute. If you run the rate too fast on a BPD lung, you are guaranteeing auto-PEEP.
And we also use higher tidal volumes here, right? 6 to 8 milliliter.
We do, and it's because these lungs have so much dead space. We often have to accept a higher COAO, what we call permissive hypercapnia, and we need that larger volume just to achieve effective alveolar ventilation.
Okay, but let me challenge you on the PEEP. If air trapping is the enemy, it feels counterintuitive to use higher PEEP, sometimes 7 to 10 centimeters of water. Won't that make it even harder for the air to get out?
That is the crucial question, and it highlights the nuance of BPD. In a normal lung, you'd be right. But the BPD lung has dynamic airway collapse. Those floppy airways, the malacia, they literally collapse shut during exhalation, trapping gas behind them.
So the higher PEEP is acting like an internal splint.
Precisely. The PEEP stents those floppy airways open, it prevents that dynamic collapse, and by doing so, it actually allows the gas to escape more completely. It's one of those weird cases where higher PEEP can actually reduce auto-PEEP by holding the exit door open.
And BPD management is so much more than just the ventilator, right? We're using a lot of other therapies.
Oh, absolutely. Diuretics are key to manage the pulmonary edema that makes their mechanics even worse. And corticosteroids are often necessary, but they come with significant risks. We try to avoid systemic steroids, but sometimes short courses of low-dose steroids or inhaled steroids are needed just to stabilize the lung enough to wean.
And that weaning process is just so slow and frustrating. A real marathon.
It is. It's a vicious cycle. The floppy airways make it hard to clear secretions. The prolonged ventilation causes more injury, and you just have to be incredibly patient.
Okay, on to another challenging one. Meconium aspiration syndrome, MAS.
MAS is just a horrific combination of problems. You have the physical plugging from the meconium, which causes this dangerous ball valve effect. You have a severe chemical pneumonitis. You have surfactant inactivation. And very often, you have associated persistent pulmonary hypertension.
Let's talk about that ball valve effect.
Yeah.
Air can get in past the meconium plug, but on exhalation, the plug seals the airway shut.
Right. So air gets trapped distally. You get this massive hyperinflation in some parts of the lung, which sets the stage for the most feared complication, a tension pneumothorax.
So the strategy has to be, above all else, avoid air trapping.
At all costs. On a conventional ventilator, that means you prioritize long expiratory times. You use moderate PEEP, maybe 5 to 7. Too high a PEEP can actually make the air trapping worse here, and you use low to moderate rates.
You just need to give that trapped gas as much time as possible to escape, and you have to be watching like a hawk for a pneumothorax.
Constantly. And for the really severe cases, this is where HFJV often shines. As we said, that passive exhalation is just better at letting trapped gas bleed off from a non-uniform lung.
And the final mandatory step for any sick MAS baby.
You have to assume they have PPHN until proven otherwise. The inflammation and hypoxia from MAS trigger a powerful vasoconstriction in the lungs. You've got to assess for it and be ready with INO if you need it.
So let's talk about PPHN directly. Persistent pulmonary hypertension. This isn't really a lung disease, is it? It's a vascular problem.
It's a failure of the plumbing. The pulmonary blood vessels fail to relax after birth, so the pressure in them, the pulmonary vascular resistance, or PVR, stays sky high.
And that high pressure forces blood to shunt from the right side of the heart to the left through the PFO and the PDA, completely bypassing the lungs.
So you get this profound systemic hypoxemia, even if the lungs themselves look perfectly clear on an X-ray. It's a vicious cycle. High PVR causes hypoxia, and hypoxia is a potent pulmonary vasoconstrictor, which makes the PVR even higher.
So our strategy has to be about breaking that cycle, pulmonary vasodilation, and optimizing the lung volume.
Exactly. Our targets have to be precise. First, oxygen. Oxygen itself is a pulmonary vasodilator, so we have to avoid hypoxia. We target a productal SPO of 92 to 98%.
And second, pH. Yeah. We used to make these babies profoundly alkalotic, but we don't do that anymore.
You know, the neurological risks are too high. Now we just aim for a normal physiological pH, 7.35 to 7.45. Maintain near normal gases.
Which brings us back to this idea of the Goldilocks zone for lung volume. Why is it that both overinflating and underinflating the lung makes PVR worse?
It's pure mechanics. If you overdistend the lung way past the UIP, the high pressure in the alveoli physically squashes the tiny capillaries that run around them. How that increases resistance. But if you underinflate the lung and it's all collapsed, the larger blood vessels get kinked and compressed. That also increases resistance.
So you need that optimal FRC. Not much, not too little.
The Goldilocks zone is where PVR is at its absolute lowest. And then, of course, we use inhaled nitric oxide, INO.
The selective pulmonary vasodilator.
Right. But the clinical pearl here cannot be overstated. INO only works if it can get to the blood vessels next to a ventilated alveolus. If the lung is collapsed, the INO just sits in the dead space and does nothing.
So you have to recruit the lung first.
You have to open the lung up, sometimes with HFOV, before you start the INO. Otherwise, you're just wasting a very expensive, life-saving drug.
Okay, so the best clinicians are not just looking at the ventilator settings. They're looking at the patient, and they're looking at their instruments. The graphics, the waveforms, and loops on modern vents give us this incredible real-time feedback.
Learning to read them is essential. It's like flying by instruments. You can often diagnose a problem before the blood gas even gets back from the lab.
Let's start with the big one for injury. The pressure volume loop. The PV loop.
This loop plots the volume you achieve against the pressure it took to get there. And the shape tells you everything about where you're operating.
So what's the most dramatic finding? The one that means you have to act right now.
The bird beak sign. It's the visual signature of volley trauma. As the loop goes up, it suddenly flattens out at the top while pressure continues to rise. It looks like a beak.
And that means?
It means you've gone past the upper inflection point. You are severely overdistending the lung. The action is immediate. Turn down your pressure, or if you're on VG, turn down your target tidal volume. now.
What about the opposite? What if the loop is almost totally flat, lying down horizontally?
That means you have extremely low compliance, a super stiff lung. You're putting in a lot of pressure and getting almost no volume. This is a big sign that you might need to give surfactant or that your PEEP is way too low and the lung is just collapsed.
So you can use the loop to find your PEEP. If you can see that lower inflection point, you know exactly where the lung starts to open. You just set your PEEP a couple of points above that.
It's a great way to individualize your settings.
Okay, what about the other critical graphic? The flow volume loop, or FV loop.
This one shows the relationship between flow, how fast the air is moving, and volume. We really focus on the expiratory limb here. It should be a nice, smooth, straight line back to zero.
But what if it's scooped? What if it curves downward?
That stooped shape is the classic sign of high airway resistance or flow limitation. The air is having a hard time getting out.
So your action is?
Check the ETT for secretions immediately. That's the most common cause. You might also need to give a bronchodilator or lengthen the expiratory time.
And the last finding on the FV loop is when it doesn't close. It doesn't return to the starting point.
Right. And this can mean one of two things. Either you have dangerous air-trapping gases still in the lung when the next breath starts, or you have a large NTT leak.
And you have to tell them apart.
You do. If the flow trace is slow and ends above zero, that's air trapping. You need a longer expiratory time. If the flow looks normal but the volume just doesn't come back, that's probably a leak around the tube.
Okay, so graphics give us the mechanics in real time, but the blood gas gives us the hard physiological data.
And we interpret it with our 2 bank accounts rule. If the PACO is high and the pH is low respiratory acidosis, you're not ventilating enough.
So you have to increase your minute ventilation.
Yeah.
Increase the rate or increase the tidal volume.
Simple as that. The big pitfall for novices is when they see a metabolic acidosis. Low bicarb, low pH. This means the baby is in shock or has sepsis or organ failure.
And the cue warning here is?
Do not try to fix shock with the ventilator. If you start hyperventilating the baby just to blow off key arrows and normalize the pH, you're causing a dangerous respiratory alkalosis and not fixing the underlying problem. You have to fix the perfusion, treat the infection.
The vent is not a tool for metabolic problems.
It is not. And finally, the opposite. Respiratory alkalosis, low Pacchiaro, high pH. This means you are overventilating. And this is profoundly dangerous for preemies.
Why?
Because that low Pacchiaro causes potent vasoconstriction in the brain. It reduces cerebral blood flow and is a known risk factor for paraventricular leukomalacia or PVL, brain injury.
So you have to decrease minute ventilation immediately. And the target C/O for preemies is actually higher than normal, right?
It is. We practice permissive hypercapnia. We aim for a PACO between 45 and 55 millimilli Hg. We prioritize protecting the brain over having a perfect blood gas.
Okay, so every clinician knows that moment of sheer terror. The baby suddenly desaturates, the blood pressure crashes. You need a system.
You need a system. And the DOPE mnemonic is your guide in that high-speed crisis.
Z is for?
Displacement. Is the ETT in the right main stem? Or is it out? Check position, chest rise, breath sounds. Now.
O is for?
Obstruction. Is the tube plugged with mucus? Is the baby biting it? This is the most common cause of a high-pressure alarm. Suction immediately. Pneumothorax. Look for asymmetry. Listen for decreased breath sounds on one side. This needs a needle in the chest, and it can be life-saving.
And finally, E.
Equipment. Is the circuit disconnected? Is the oxygen tank empty? A quick, systematic check of your machine. Using DOPE ensures you don't miss the obvious things in a panic.
All right, as we get into our final section here, we have to pair all this technical mastery with a real understanding of the ventilator's potential for harm. It's a life-saving tool, but it's also a double-edged sword.
It absolutely is. And we have to internalize the 4 major ways we can cause ventilator-induced lung injury, or villi, so we can prevent them. And as we said at the start, the #1 enemy is volutrauma.
Injury from overstretching the lung, not from pressure, but from the volume that results from that pressure.
Exactly. And volutrauma is the primary driver of the inflammation that leads to BPD. And the prevention is using safe, targeted tidal volumes 4 to 6 millilkg and using volume guarantee to make sure you never overstretch that lung.
The second injury is attalec trauma.
The damage from repetitive opening and closing of lung units, shearing force, and the prevention is simple. Adequate PEEP. Keep the lung open and stable.
Then there's biotrauma.
This is the systemic fallout. When you stretch and shear the lung cells, they release inflammatory cytokines into the bloodstream, and that systemic inflammation contributes to multi-organ damage and, eventually, chronic lung disease. The only prevention is to use the gentlest strategies possible.
And finally, Oxygen toxicity.
High concentrations of oxygen create free radicals, and the premature lung just doesn't have the antioxidant defenses to handle it. So we have to constantly work to optimize our MAP so we can drive down the FiO. And we target our sats carefully, 91 to 95% for preemies.
So the takeaway is crystal clear. Volley trauma, not barotrauma, is the greatest threat. Volume guarantee plus adequate PEEP is the cornerstone of lung protection in the NICU.
That's the whole philosophy.
And as clinicians working with these incredibly fragile patients, we're constantly facing ethical decisions that really define the moral boundaries of what we do.
We are. We have to understand that just because we have the technology to sustain life, the decision to use it or to starve it carries an immense weight.
One of the principles we follow is that withholding care and withdrawing care are morally equivalent. Ethically, they're the same. But psychologically, for families and for staff, they feel very, very different.
They do. Withdrawing care can feel like an active intervention, even when it's the right thing to do. So we have to approach those conversations with so much empathy and transparency.
Which is why shared decision-making is everything. Our role isn't to dictate, it's to be an expert guide.
We provide the most accurate prognosis we can. We lay out the options. We talk honestly about the potential for long-term disability and quality of life, and then we listen. We elicit the family's values and their goals. They are partners in this.
And this is never more intense than in the gray zone of viability. At 22, 23, 24 weeks gestation, the decisions there are so heavily value-laden.
They are. And we have a huge responsibility to provide our local up-to-date data, not just survival rates, but rates of severe neurodevelopmental impairment. The conversation has to be about more than just numbers. It has to be about what that family truly defines as an acceptable quality of life.
Okay, so to bring this all together, let's just run through the Master Clinician's checklist. The systematic approach to managing any baby on a ventilator.
First, pathophysiology. Is this a stiff RDS lung, a floppy DPD lung, or a vascular PPHN problem? Everything flows from that.
Second, estimate the time constant. Short time constant means fast rates, short T. Long time constant means slow rates, long T. You have to match the timing to the mechanics.
Third, mode selection. Non-invasive first if you can. If you have to intubate, volume guarantee should be your default. High frequency is a rescue therapy when conventional modes are failing or require dangerous pressures.
Fourth, setting the parameters. VT is low for RDS, higher for BPD. PEEP is adequate to stay above the LIP, and maybe even higher in BPD to splint the airways.
Fifth, monitoring. Look at the baby first, always. Then look at the graphics, the bird beak for volley trauma, the scooped loop for resistance, and finally, the blood gas. Permissive hypercapnia for preemies. Don't chase numbers.
And the final, and maybe most important step, weaning.
Always be weaning. The ventilator is a temporary bridge. It is never the destination. Every single day on that machine increases the risk of injury.
So we've really journeyed from that core foundation of separating oxygenation from ventilation all the way through the physiology of time constants to the strategic use of VG and into these tailored battle plans for specific diseases.
And the lesson, I hope, is that this field is all about constant synthesis. You're always putting pieces together.
The era of just follow as a recipe is over. We now have the tools, especially the graphics, to see lung mechanics in real time and prevent injury volley trauma, atolite trauma, before it ever shows up on an X-ray or impacts that child's future.
And by mastering that physiology and preventing that injury, we ensure that we're not just sustaining a life, we are protecting the future quality of that life.
So I'll leave you with this final thought. If we know with certainty that every centimeter of pressure and every milliliter of volume we deliver carries the risk of permanently damaging a premature lung, how does setting every single one of those ventilator knobs become not just a technical choice, but a moral imperative regarding that patient's entire neurological and pulmonary future? That's the weight we carry into every shift.